shall I introduce Dr. Emrah Egemen? Dr. Emrah Egemen is coming from the Department of Neurosurgery at Pamukkale University in Denizli, Turkey. He's an associate professor there. And Dr. Egemen is going to give us a talk on BP shunt complications and innovation. Thank you very much. Looking forward to your talk.
Thank you, sir. Let me share my presentation. So can you see the slides?
Yes.
Can you hear me well? Okay.
Yes, we can.
So first of all, I would like to thank Professor Zileli and Professor Lucy for their kind invitation, and thank you for Dr. Manas and Dr. Satova, their insightful presentation. So today I will talk about the ventricular peritoneal shunt complications and recent innovations. So as you know, as Dr. Manas taught, endoscopic third mechanisms become increasingly common in treatment of hydrocephalus. However, the shunt surgery is the most common, most widely performed treatment in hydrocephalus. And unfortunately, last 2 decades, the rate of shunt-related complications has shown a little improvement. That's why I'm giving this talk today. So let's talk about the basics. So the failure rate of a ventricular peritoneal shunt within the first year after initial shunt placement is 10 to 25%. However, if you follow patients long enough, the failure rate exceeds the 80% within 15 years. So eventually you will see the complications with ventricular peritoneal shunt patients. And we already know that 17% of patients will need 3 or more revision surgery. So I usually tell my patients once a shunt is placed, most of you will need an average number of 2.5 revisions. And if you're lucky, it might be just be one surgery. But if you are unlucky, you may need many surgeries. My personal record is 16 shunt revisions in 1 year. So, but this is not about the luck. The problem is the risk factors. What are our risk factors? So we know that the higher risk factor in children compared to the adults, they have 4 times greater than the risk factors about shunt revision. If you have early shunt complication, that means later you will have increased risk of a late shunt complication. Also, the type of hydrocephalus also matters. So, congenital hydrocephalus, especially when associated with spina bifida, carries the highest risk. In contrast, communicating hydrocephalus has a lower risk. And as we talked now, the normal pressure hydrocephalus has the lowest. So, so far we know that the male sex and the low socioeconomic status have been linked to higher shunt-related complications. So, sorry. So shunt-related problems often begin with the surgery or just after the initial surgery. One of the possible complications is intraparenchymal or intraventricular hemorrhage during the insertion, as we see, and this can lead to seizure, usually caused by the cortical irritation or the fluctuations in the intracranial pressures. So surgical planning or poor technique can result in incorrect catheter positioning, which may require early revision surgery. And finally, shunt infections most commonly occur within the first month after surgery. So you can see the hemorrhage around the ventricular catheter around here. And as you see, these patients operated like, as I said, 10 times at least. And you can see the entrapment on the temporal horn there. So we tried to insert the catheter inside it, but as you see, we shifted the midline there, so it obviously needs the shunt revision. So, what is shunt malfunction? Although we know that the obstruction and the infection the most common reason for the shunt malfunction, but there are another rare reasons like pseudocyst formation, bowel perforation, and one of the serious condition that overdraining, which leads to slit ventricle syndrome or even worse, subdural hematoma. Shunt obstruction most commonly occurs in the proximal catheter. One reason is that the brain tissue can block the catheter during insertion. That's why we use removal sheet during placement to avoid it. As you can see there, the proximal catheter has multiple holes. This design allows the catheter to continue working, even some holes become blocked till the all of it blocked. One key risk factor for obstruction is the surgical technique. If you place the tip of the proximal catheter near the choroid plexus, most probably this choroid plexus encase the catheter and leading to blockage. The presence of blood and high protein levels also in the CSF may also contribute to obstruction, but this is somewhat controversial. What I mean that, for instance, for premature babies with intraventricular hemorrhage, we know that they are strongly associated with shunt obstruction. However, shunt placement after hydrocephalus due to subarachnoid hemorrhage does not seem to carry the same level of risk. Um, so, what is the innovations about to solve this shunt blockage? Now it seems that programmable shunt valves appear to be promising solution for shunt obstructions. Some studies report that in patients under 1 year of age, programmable valves can reduce the risk of obstruction from 30 to 9%. So this affects thought to be due to the adjustable pressure of settings. So by preventing the over drainage of the valve, so you can reduce the chance of the debris or cells being pulled into the catheter, so you can avoid the obstruction. So how can we confirm shunt obstruction? So it is quite challenging. The first step we usually do a manual examination on the shunt. When we pump the valve and observe the CSF drainage, you expect it to refill. If it does, this suggests that the shunt is functioning properly. If refilling does not occur, this may indicate obstruction. However, the lack of the missing of the refilling does not always mean malfunction. For example, in split ventricular syndrome, if there's no CSF in the ventricle, so you can't expect the refilling, of course. So conversely, in the distal catheter, also obstructed, the valve may still refill after pumping. So that may lead to false impression that shunt is working. So that's why we should evaluate the patients with neuro imaging like CT, MRI, maybe lumbar puncture to measure the pressure. And there we have some other conditions like in past 2 decades, I remember when I was a resident, we used this radionuclide shuntography to understand if there's a CSF flow inside the catheter. However, it is invasive and involves radiation exposure for the patients. So in recent years, ultrasound-based methods have been developed to evaluate CSF flow non-invasively flowing. These techniques are gaining popularity, and it seems the sensitivity is increasing from 70% to almost 100% as the last paper I found. So this is the most common problem with the shunt. The second one is the shunt infection, and which leads to shunt malfunction. So as we know that about 70% of infections occur within the first month and 85% within the first 9 months. So if the infection occurs after 9 months, we call it late shunt infections. Early shunt infections are usually caused by intraoperative contamination during the initial surgery. So we do it in OR. Late infections, on the other hand, often result from peritonitis, abdominal pseudocyst, bowel perforations, or hematogenous spread from the distant infections. The most significant risk factor seems to be young age, particularly the premature infants who are the most vulnerable one. So other risk factors include the postoperative CSF leak, glove holes during shunt surgery, low socioeconomic status, previous shunt infections, and etiology of intraventricular hemorrhage, as I mentioned before. The most common causative organisms seems staph epidermidis and staph aureus, while gram-negative ones also have shunt rarely seen. More than 80% of shunt infections occur within, as I said, the first month. So, but the late shunt infections usually originate from the other sources. So, enterococcus, Escherichia coli, and Streptococcus are the main reason for the late shunt infections. So, how do we identify the causatives? How we understand which bacteria cause these shunt infections? Mostly, we diagnose these bacteria from shunt reservoir, and sometimes we can use lumbar puncture or blood culture. But we shouldn't forget that if we are not sure about the shunt infection, we didn't inoculate skin flora to inside the ventricle. So this sampling thing should be very carefully and in sterile fashion. So treatment of shunt infection is a prolonged process which patients spend weeks, months inside the hospital. Therefore, the first priority should be prevention. So by optimizing sterile technique and reducing the time procedure is the most important things for avoiding the infections. But however, once we have shunt infection occurs, the initial step is to remove the infected hardware. An external and ventricular drain should then be placed and for allowing continuous CSF drainage. Sometimes some centers they don't put EV, they only remove the and don't remove the hardware. They externalize the existing shunt and wait till the CSF becomes sterilized. And other clinics attempts without changing any chance direct medication or intravenous antibiotics. But the success rate in such cases is typically less than 9%. So the first thing is the removing the infected hardware, then placing the external ventricular drainage. Uh, to pre sorry. To prevent the infections, especially in patients under 1 year of age, antibiotic impregnated catheters can be used. However, these catheters do not prevent bacterial cell adhesions. So, when the patients have shunt infections and when we change it with the antibiotic impregnated catheters, the patients can have antibiotic resistance shunt infections, which more severe conditions. So to avoid these cell adhesions or bacterial adhesions, new elements tried to coat it with the catheter. This is one of the innovations that I found is the polyvinyl pyrrolidone in terms of avoiding the cell adhesions. So another rare cranial complication as related with the shunt overdrainage is the development of subdural hygroma, or in more severe cases, a subdural hematoma caused by rupture of the bridging veins. This occurs about 5% of the shunt patients. To reduce the risk, we must avoid creating CSF fistula during surgery. First, the dural incision should be minimal, just enough to insert the catheter into the ventricle. So if you don't do it, you can see the leakage under you can see the CSF fistula under the subcutaneous tissue. Second, the subcutaneous tissue should not be excessively dissected while preparing the pouch for the valve. Otherwise, you can see the collection over there. If CSF leak or overdrainage occurs, the ventricle may become slit-like, and a condition will call it slit ventricle syndrome. This can lead to subdural hygroma and eventually the subdural hematoma. In such cases, evacuation of the hematoma and removal of the shunt may be necessary. So excessive dural incisions, in case of excessive dural incisions, and especially in the endoscopic surgeries, then the shunt insertion, you can see the pneumocephalus as you see here. So to prevent the overdrainage, Programmable shunt valves can be used by adjusting the pressure settings according to the patient's needs. Such complications you can see can be avoided. The peritoneal complications such as abdominal ascites, peritonitis, or abdominal pseudocysts are often associated with the shunt infections. They are rare conditions, but important. They sometimes need to change the distal catheter to pleura or atrium. So, what is pseudocyst? An abdominal fluid collection that forms around the tip of the distal catheter and surrounded by the fibrous tissue without epithelial lining. That's why we call it pseudocysts. So in such cases, the shunt system should be removed again. So you can either wait for the pseudocyst to resolve spontaneously after removing or perform ultrasound guided aspirations. However, in my opinion, I do different things that the most effective approach is the cut of the distal catheter in the middle and externalize it. So while leaving the distal end inside the cyst, this way you fully drained all fluids in 6 to 8 hours, then you can take out the remain part. Another problem is bowel perforation or displacement of the shunt is a serious complication of the shunt systems. So theoretically, it may occur due to the stiffness of the catheter, causing chronic irritation to the bowel wall, or sometimes we believe that this can be allergy, silicone allergy. So the most commonly reported presentation is the protrusion from the anus. However, it can also occur through the other routes such as transferal protrusions or migration into the inguinal canal. So scrotal migration is more likely in the younger patients, typically under 3 years old of age, before the inguinal ring has fully closed. So in such cases, the shunt can be repositioned laparoscopically and the inguinal ring can be sutured to prevent the recurrence. Also, you can see the rare case reports with the bladder perforation that leads to peritonitis. Another rare complication related to shunt involves subcutaneous and skin issues. First, we know that infection can spread to the skin and may cause the skin dehiscence. Most cases of skin dehiscence are associated with the allergic reactions, not with the infections, but we should know it. Shunt migration is another concern, which is securing the valve to the periosteum is very important on that issues. In patients who were shunted long time ago, you can see the calcifications over there. So leading the tethering to the skin and causing pain. So over time, silicone material loses its elasticity, and because of this tethering, the catheter may rupture and become disconnected, which needs to be removed and changed, which catheter is displaced. Okay, so those are the complications. What are the best innovations? I think perhaps the best innovation is in the shunt management, also in the shunt failure, is endoscopy. So endoscopic third ventriculostomy, especially post-shunt ETV, has showing promising success in selected cases of hydrocephalus. What I mean? That's we call it secondary ETV. Nowadays, only viable alternative in previously shunt-treated patients appears to be ETV. Many studies have reported the success of secondary ETV in context, and they reported some predictive factors. So predictive factors for ETV success include clear visualization of basilar artery during endoscopy, as you can see here. Presence of obstructive hydrocephalus as primary etiology, and short interval between the initial shunt surgery and the ETV. On the other hand, certain factors are associated with the ETV failure, such as early age of first shunt insertion. In this paper from 2015, they said particularly under 6 months of age, and history of multiple shunt revisions are related with shunt ETV failure. So in 2023, there are two meta-analyses, and they tell the almost same things. if the overall success rate, secondary ETB, when you have shunt failure, is 63%. As mentioned earlier, predictors of success included primary obstructive hydrocephalus, patient age over 36 months, and the presence of aqueductal obstructions. On the other hand, multivariate analysis showed that the age under 36 months, primary inflammatory hydrocephalus, as you can see in this ETB patients, very narrow ventricles, and you can see the inflammatory changings. So that shows the predicting factor as a ETB failure. So in this meta-analysis, the authors aim to evaluate the decision-making strategies for managing shunt malfunctions. The key question is, as Dr. Manas said, as a first treatment, but it's same for the shunt malfunction, to perform whether to perform a secondary ETV or proceed with the shunt revision. So as shown in the diagram, if the patient presents with communicating hydrocephalus, so most we prefer shunt revision. Even the patient has obstructive hydrocephalus, but it's under 36-month-old, also we propose shunt revision. In all other conditions, think all shunt malfunctions such as infection, obstruction, and other complications. Secondary ETV should be tried. And as I told, the overall success is 63%. Another useful tool is shunt scope. In cases of over-drainage, where the ventricles become slit-like, it can be difficult to locate the ventricle during shunt revision, especially in patients who were shunted long time ago, as the brain may have lost its elasticity. So even there's shunt malfunction, you can't see the ventricular dilation, so you can miss the ventricle while placing the new catheter. So in such cases, shunt scope can be very helpful. The camera is inserted into the catheter, allowing direct visualization, and it can also be used in cases of the isolated fourth ventricle, where a shunt can be placed through the aqueduct into the fourth ventricle. So I have an exemplary case here. You can see the shunt scope vision. It's not in high resolution because of this fiber optics. It's very thin. We use in the catheter. As you see, we perform shunting as usual. Now you see the parenchyma, and we now reach the lateral ventricle. You can see the choroid plexus here, foramen Monro, and you can, by this shunt scope, you can place the where you want to the catheter. So I continue with the catheter and the camera, and I let the catheter inside and pull out the camera, as you can see here. Another serious conditions, shunt infections under 1-year-old age. You can see these multicystic infections, and you can see the debris around here. So in that case, we want to put one shunt after the eliminate the infection, but you need to connect all cysts in one. So thanks to Benjamin Ward, is popularized by Benjamin Ward, these flexible endoscopes may help to connect this cyst to each other. However, in my experience, it needs 3 or 4 surgeries to connect all cysts together, because you perform surgery and you somehow in half an hour you get lost. So it's better to go out and take an MRI to see what did you do. So you can see this same patient's endoscopic view. This is rigid endoscope. I don't have flexible endoscope. So you can see there these infections left out, the debris around there, and you try to find some anatomical things, and you make ventricular washing to somehow eliminate the infections here. I took this out just for sampling. It's impossible to take it all. Just I use irrigating. And in the end, after several operations, you can put shunts into the fourth ventricle by utilizing the shunt scope. So, as I told before, isolated fourth ventricle is very rare condition. It's associated with the multiple shunt revisions. These patients come to me like 2 or 3 months ago, 28 years old male. They had several shunt revisions, but without removing the old one. You can see 1, 2, 3, 4 shunts in one patients, and also you can see the isolated fourth ventricle here. So when I enter by endoscope, you can see the blurry water. That's because I don't create a bleeding. It was, I think, because of the high protein level. So all shunts taken one by endoscope because some of them is floating inside the ventricle without connection or without extracranial connection. So I found that shunts hold with the punch and take this out. So I performed a conductoplasty and put an EBD to have the continuous CSF drainage. And in the end, I think I can't remember the exact data. 5 to 7 days later, I put shunt inside the fourth ventricle, utilizing by the shunt scope. You can see the removal of proximal catheter. So last complication I can tell is very rare condition. I have only 2 cases about that. It's secondary synostosis associated with the shunt. So when we insert shunt, especially under 1 year old patients, the low pressure shunts may close the suture because there's no pressure on the suture. And for this head growing, we need pressure by the brain. So when there's pressure shunt start to work, so the, the suture become useless. So if we have open sutures, just the deformational plagiocephaly, remolding helmet can be used. But mostly all all sutures are synostotic. So because pansynostosis and open mold reconstruction is needed. Um, so I have an exemplary cases that these patients operated 5 times for shunt revision, and when they presented to me, you can see the 2 shunts, and with the manual examination, we decide that the shunt at the left it doesn't work. So we decided to take out the shunt and make the cranial expansion to give space to the patient. As you can see here, there's no suprachiasmatic space. Uh, so after the surgery, you can see the suprachiasmatic space around here, and the left shunt is removed. But in 3 days, we realized that ventricle is becoming larger and larger and larger. So when we investigate, by the way, thank you, Nargisa, that warning that this careful investigation of the radiologic investigant is really important. We found that the tip of the proximal catheter is inside the brain. So, because it's partly functioning by the manual examination, we decided to endoscopic relocation. As you can see, ependymal line on the proximal catheter, and we start to dissect this line one by one, try to find these multiple burr holes if to check if it still works on there. So you can see, and in the end, here the holes are open, and in the end, I relocate inside the lateral ventricle. So in that case, we didn't make a shunt revision. So this is the 1 year follow-up. As you can see here, the ventricle is regressed. So commonly, this is my talk. Thank you for listening. And if you have questions.
Thank you very much, Dr. Egemen. That's an excellent talk. You covered almost all the complications. The complications for hydrocephalus and shunt surgery are endless, but elegant talk. Thank you. Dr. Miwa, do you have any questions for Dr. Egemen?
Thank you for the perfect presentation and very interesting, very nice lecture. And I have a question about the infection. And do you think the antibiotic preparation tubes, such as a Bactrim, are effective? And do you use the only in pediatrics and or all ages for
Uh,
the
Actually,
antibiotics preparation tube?
so I don't use antibiotic impregnated shunts now because I encounter with these antibiotic resistant infections. So when you have shunt infections, I mean staph epidermidis, staph aureus, it's easy to manage it. But when you have resistant drug resistant infections, the condition is really hard. So I don't prefer to use antibiotic impregnated shunts.
Okay, thank you very much. And I have one comment, and you use a shunt scope, and also the fiber scope is a very good technique and a very good device to treat a complicated hydrocephalus or remove the debris. I'm very interesting. Thank you very much.
Thank you, sir.
Dr. Egemen, there's a post a question on the chat box. ETV use below the 6 months of age in post-infectious hydrocephalus, um, uh, and do you do them in post-infectious
So,
hydrocephalus?
we all never perform what we read from literature. I always try secondary ETV, even under 6 months olds. But the results is obvious. I have 28% of ETV success under 2 years old age, but 55% of success over the 2 years old age. So, but this is the only chance you can use for the patients. I mean, 28% is not low. So I try secondary ETV even with the patients with under 6 months olds.
Thank you.
Thank you. Dr. Emrah, I just wanted to give a comment in terms of ETV that most of the time we have to consider the decision of parents. There are parents who are completely resisting their
Yes.
babies to be shunted. So they will say, go for the first time ETV, we want the second time ETV. So this is also important, I think, point. And maybe Dr. Emrah is also facing these
Yeah.
problems.
What I tell the patients, so what we said before, once a shunt, always shunt. So the parents educated by this motto. So I always tell them I can try with ETV, but the success rate is no more than 60%. But what I see, parents are really enthusiastic to see if they can leave their child, let them shunt free. So they try it. So in cases like I showed you with inflammatory cases, I always put EVD for insurance, as I can told. But if I follow patients 3 or 4 days, and if there's no CSF leak and patient is good, I let them to go home. But in case of CSF leak or headache or ventricular dilation, I put shunt back. So they are prepared for at least 2 surgery.
Thank you. Dr. Egemen, I have two comments. One is that in terms of the antibiotic impregnated catheters, in the UK, we have found that to reduce the shunt infection rate quite significantly. And the recent study that came from Liverpool, once again, they did not have a sham control. They had three different shunt catheters. We initially thought we had, there was a report about antibiotic resistant infection, but that hasn't been a problem that we nowadays see in the practice. The shunt infection rates have really come down with the antibiotic impregnated catheters for us anyway. I know that the different patients, different countries different because here different antibiotic practice, because in Britain patients are very rarely given antibiotics, so they are more sensitive to antibiotics. So that's one. The other question, I think, in the 2 minutes that we have, I think the inserting a VP shunt is not technically as difficult as what Dr. Benzel does, complex spine surgery or vascular surgery, but it needs absolute meticulous preparation, meticulous thinking in terms of first of all in terms of how to treat, then a meticulous surgical technique, meticulous follow-up. And shunt surgery is usually relegated to residents or junior colleagues, mainly residents. Do you think that's one of the main problems for the first bad shunt and then it starts a shunt, or you don't see that in your practice? What's your thoughts on that?
Sorry, I missed the question.
The question is that should the shunt operations be allowed to be done by residents without?
Okay, as you say, this is a simple procedure. Resident, I perform under my supervision because somehow they need to learn, but it's quite stressful operation for them.
Thank you very much. Very much to all the speakers for their excellent talks, and also for very interesting. Thank Professor. Before that, I will give it to Dr. to hand over to Professor.
Yeah, it was great panel, really. I enjoyed all the talks. And
Yes.
now